Today I'm going to present an interesting patient which we thought that patient of drug-induced hepatitis. Before we go on to the case, let me tell you something about drug-induced liver injury, which is broadly defined as a DILI. Though certain medications in the allopathic medications like antitubercular line of medications, antibiotics like amoxiclavs, and various oral contraceptives, chlorpromazine, antifungal drugs are the ones in the allopathic groups which are supposed to be associated with DILI. The use of complementary and alternative medicines have increased worldwide, mainly for acute and chronic diseases. And with the use of these drugs, it is observed that drug-induced liver disease incidence is also rising. What are complementary medicines? Complementary medicines are the ones which are given along with evidence-based medicine without any evidence, scientific evidence. Alternative medicines, they replace evidence-based medicines. So complementary medicines are added as a supplement to evidence-based medicine, while alternative medicines replace EBM, evidence-based medicine. Ayush, which is an officially recognized system of alternative medications in India, it is governed by the Central Council for Indian Medicine. What Ayush stands for? Ayush stands for Ayurvedic, Yoga, Unani, Siddha, and Homeopathy medicines. What is the prevalence of these complementary and Ayurvedic medicines? Because the allopathic medicines causing drug toxicity is very well known. But these medicines, generally the history is not asked. And what is the prevalence? That would be interesting to see. Regarding complementary and alternative medications, there is a strong general public, political, cultural, as well as social acceptance to these medicines. But what it lacks is a scientific evidence-based science, the basic science, and the rigorous clinical trials which are based in the research have been lacking. The prevalence varies from different countries and different surveys, and it varies from 10% to 76% depending on the region involved. In a large survey by Harris, 49 surveys in 15 countries. Highest in Japan, South Korea, Malaysia. However, the Chinese and Indian surveys were not included in this. Indian perspective, what is the Indian prevalence? From the south, in Bangalore, there was a large single center study of 313 DILI patients, out of which 1.3% were due to, figure was very small, and 50% died due to progressive liver failure. Abby Phillips published its data in 1440 liver disease, out of which 94 were the liver injury, which was secondary to Ayurvedic herbal medications, roughly less than 1%. And the 33 causality was established by the Rosell-U-Clough causality associated scoring system. The male sex was dominated. Medium duration of liver injury was 28 days. Reason for use was GI symptoms. Mortality was 20%. Sometimes drugs lead to development of autoantibodies, leading to um, autoantibodies being positive. There is a data on use of complementary Ayurvedic alternative medications in cirrhosis. In one first study, 2 out of 3 patients they use complementary medications. One third had ACLF and 1 in 2 died. So 2 out of 3 used complementary medication, 1 in 3 developed ACLF, and 50% was the death rate. In second study by Dr. Devabhavi, 72% use a complementary medication, and the common cause of CLD was alcohol. Complementary medication associated liver injury can be classified as 3 types: predominantly hepatocellular, cholestatic predominantly, and the mixed type. There is something which formula which is called as R value. The discussion does not permit me to discuss about this, but if you have a value of more than 5, then it is hepatocellular. If you have a value less than 2, it is a cholestatic, and if you have between 2 to 5, it is defined as mixed. Hepatocellular pattern of the liver injury is the commonest. In one of the Chinese studies of acute liver failure from January 2007 to December 2012, 177 patients were there of acute liver failure. 63% died. Drug-induced toxicity was the commonest cause, followed by indeterminate cause and viral hepatitis. And traditional Chinese medicines were the ones which were commonly responsible for it. Ayurvedic medicines related hepatotoxicity and known plants which are associated with hepatotoxicity are few. The reports are sparse. There is one plant, Centella asiatica, or called as Gotu kola, that can lead to acute liver failure, granulomatous hepatitis, and severe liver injury. Bakuchi tablets can give rise to liver disease. It's an extract of Soralia caryophylla, Cadine, and Brahmitab. The famous Live 52 did more harm in child C cirrhosis, leading to ban. Phillips et al. In his study suggested that 40% of the Ayurvedic medicines were responsible for the hepatotoxicity, and many of them they have detected lead, mercury, and arsenic, which are the heavy metals, together with volatile organic compounds. This is the table indicating the various medicines and from the various countries, which is beyond the scope of my this thing. You have different preparations of Ayurvedic leading to hepatotoxicity. Now we come to our case. This was a 49-year middle-aged lady who presented to us first time in September 2020. She came in the OPD with prodrome in form of anorexia, nausea, vomiting, followed by jaundice. There was a mild pruritus. There was no history of abdominal pain, no history of fever, no history of joint pain, skin rash, no history of weight loss, bleeding, diarrhea. So she had a prodrome followed by jaundice, suggestive of hepatocellular jaundice. She had bilirubin of 10.2, diuretic predominant, enzymes elevated to more than 40 to 50 times. Albumin was maintained, the alk phos was normal, just mildly elevated, INR 1.36, no eosinophilia, ultrasound normal. This time the CBC, KFT, thyroid was normal, HbA1c, HC were negative, AE, and then denied history of neck. The patients at this stage was advised liver biopsy because all the parameters were negative, but she refused to go get it done and the jaundice subsided. This time, our diagnosis was that she has seronegative acute viral hepatitis, started on UDCA, supportive treatment. Jaundice got better, symptomatically better, LFT normalized, was asymptomatic over next 6 months. What happened was she had COVID in the month of April 2021 during the second wave, received medications in the form of azithromycin, doxycycline, ivermectin, sorbilin. It was short lasted, no respiratory symptoms, was at home, did not require hospitalization. But by the family members and other people advised to take immunity boosters, we started from the first week of May. She had started weakness and fatigue. Second week of May, jaundice and mild pruritus were noticed on 18th of May. The LFTs on 18th of May suggested a liver enzyme elevation, remarkable liver enzyme with conjugated hypertension, and the same was the pattern throughout till middle of June. This time we decided that we should have because it was the second episode of jaundice, we thought that we should evaluate completely. HIV, IgM negative, hepatitis B, C negative, anti-HBC total, core antibodies negative, ANA negative, asthma, anti-alchem negative, IgG was within normal range, ceruloplasmin was normal, G6PD normal, LDH, B12 normal, tissue TTG, IgA negative, KF ring negative. So all non-invasive markers were not there. The follow-up revealed that she continued to have deep jaundice and liver enzyme elevation. The platelets were low, so we were worrying whether she is going in for acute on chronic liver disease. Eosinophilia was 4%, INR was 1.5. So the final diagnosis at this stage was recurrent hepatitis, very cause, varices negative both the times. Detailed drug history was taken and it was thought that she was during first wave of COVID, July, August 2020. She had immunity boosters, received RAS containing Ras juice containing giloy, amla by Baba Ramdev, and along with she had kadha concoction of dalchini, ginger, jaggery and tulsi. Also the same preparation of giloy and amla juice by Baba was started in last April last week and May 21. So both these times, these giloy and the other concoctions were there. So we were started thinking that whether this is responsible for this delay. We decided to get the US guided liver biopsy and the biopsy was done. The liver biopsy specimen which we obtained showed that they were very good biopsy, 20 fragments of liver tissue seen with 11 portal tracts. It showed feathery degeneration, accumulation of neutrophilic and lymphocytic infiltrates, Kupffer cell hyperplasia, congestion. There is a portal triaditis, ductitis, interface hepatitis, and bridging necrosis, and stage 2 fibrosis. There is no evidence of cholestasis, rosetting, steatosis, granuloma, or neoplastic. So the impression was chronic active hepatitis. Possibility of drug-induced hepatic injury cannot be ruled out. This is the histology. You can see the accumulation of inflammatory cell infiltrates with areas of necrosis and portal triaditis and interface hepatitis. So the final diagnosis that whether the patient has drug-induced hepatitis, why we felt that both the times the patient had jaundice, she had consumed giloy as an immunity booster, as a juice. So we felt that that could be the agent. So we were not knowing that whether this is the, so we had a telephonic conversation with other people in the country whom from South, Kerala, Coimbatore, then from Mumbai, Chandigarh, there was a confirmation that these people are also in the COVID era seeing a lot of patients with jaundice whom the diagnosis cannot be labeled. So that led to suspicion that possibly it could be drug-induced, giloy-induced hepatitis. Our observation was that there was sudden increase in cases of hepatocellular jaundice during the COVID era without any known etiological factors. Re-challenge was seen in 2 of our patients, suggestive of a strong association between giloy and jaundice and liver injury. Temporal association with giloy consumption and jaundice was observed in our patient. Giloy is being used as an immunity booster. Whether COVID is responsible is big question mark, but our patient did not have COVID in the first time but still had jaundice. We feel that this is an observation of the association, whether the causal association needs to be evaluated. Same is the observation of other gastros from India. What is the mechanism needs to be studied. Yes. Let us see what is the evidence in the literature for giloy-induced liver injury. This is one presentation which was there in 2021, BMC Complementary Medicine and Therapies, where they have described 3 cases, out of which one was secondary to consumption of giloy / tinaspora medicine. Herbal, this is the second presentation by Abha Nagral, very recent journal, Journal of Clinical and Experimental Hepatology, where they have reported case reports of 6 patients who has consumed giloy, and as a result of which they had acute liver injury secondary to giloy during the COVID-19 pandemic. And the mechanism of liver injury was mainly immunological, as suggested by antibodies positive in many of her patients. Most of the presentation was like acute hepatitis. What is Midas experience? We must have seen around more than 10 patients in this COVID pandemic with jaundice, with history of giloy consumption, with all the parameters being negative, except that we must say that we did not test for 3 things: cytomegalovirus, herpes simplex virus, and Epstein-Barr virus. But we had these data of 5 patients Um, the age group varied. Comorbidities were hypertension, hypothyroidism in one patient. Clinical presentation was like jaundice, pruritus in three patients, and with underlying chronic liver disease in three patients. Most of them they had hepatocellular jaundice with liver enzyme elevation, which was much more. The alkaline phosphatase, our lab report normal is 120, so it was hardly 1.5 times elevated. INR was quite deranged in most of them. Autoimmune profile was done, and it was positive in two patients, negative in two patients, and weakly positive in one patient. So two patients had definitely autoimmune profile positive in the form of positive ANA, but asthma, anti-LKM, and mitochondrial antibodies were negative, and the IgG was again not very significantly elevated. Could have a liver biopsy in three patients, out of which one was a cholestatic type of injury, one was a hepatocellular injury. The third report patient unfortunately expired, so the report could not be traced. But we're trying to get into touch with the pathologist and patient and trace their liver biopsies. So, as I told you, out of 5, 3 patients expired, and all of them they had underlying CLD. So this is to show you the nutshell, the data of all these 3 patients. As I said, the autoimmune parameters positive in the form of ANA was positive in 2 patients, weakly positive in 1. Liver biopsy, one showed cholestatic and another showed hepatocellular. 5 out of 5, 3 patients expired, and most of them expired had CLD, chronic liver disease. The re-challenge was seen in 2 of our patients, so which confirmed the diagnosis of Giloy-induced hepatitis. Thank you.